So foot and ankle exam, I think, is best done first with the patient seated and then having the patient walk. We're going to look at the anatomy of the foot and ankle. You can look at the joints to see if there's any swelling in there. Oftentimes, if there's an injury in the foot, like a fifth metatarsal fracture, there'll be swelling right around the fifth metatarsal base. If there's an ankle injury, you'll have a lot of swelling, oftentimes laterally, but you can, in severe cases, medially have swelling as well. If you have a forefoot injury, you might have swelling around the forefoot as well. Then to continue with the inspection, we'll have the patient stand up. And we'll look at the feet and whether there's collapse, and we'll have the patient turn around. And we look for, all the way around, we look for a finding called too many toe sign, where if they have midfoot collapse, their toes will be seen on the back, from the back side. If they're normal, you won't see the toes, will be hidden by the gastroc soleus complex Achilles and the bones. If they do have too many toes and they're collapsing midfoot, we'll have them raise up on their toes and see if it self-corrects. If the hindfoot valgus self-corrects on raise up in toes, that'll be a positive finding that'll be helpful for us in treatment. Okay, let's back up here. So let's start with dorsiflexion of the ankles, and then we'll do plantar flexion, and then we'll do external rotation, both sides. Usually I like to do both sides symmetrical to compare side-to-side variation, then internal rotation. You can also do something come back to neutral, inversion, where you rotate in a little bit, inversion, and external rotation, or eversion the other way. Okay, that's enough for range of motion in the foot and ankle. The other test we're going to do is palpation. Now, for palpation, it's probably best so you can see the fibula, you can see the tibia, you can see part of the talus here. This lateral process of talus is a tricky one because that fracture happens, x-rays are negative in 40% of patients and can cause severe disability if we don't pick up this fracture early on. The fifth metatarsal, and you can palpate the base of the fifth metatarsal, the talus, the fibula, and the tibia, and the joint. You can feel the joint. You can feel on the inside part the anterior tibialis, which comes and attaches to the navicular bone. And if we rotate out the ankle, we'll see the posterior tibialis come across and attach right here to this, we call the in spot, because of the common injuries in the navicular bone. Now to check back here, you'll check the digitorum and the flexor hallucis and the neurovascular bundles back in here. With the midfoot, we have the cuneiforms, the navicular bone, and the cuboid bone over here, and then they articulate with the 5 metatarsals. So we want to palpate the 5 metatarsals for pain, and if we're not sure if they have a stress fracture or a soft tissue injury, we can also axial load the metatarsal individually. So this is the 3rd metatarsal. So if they have a stress fracture, it'll hurt with palpation, but so can a soft tissue injury. But if we axial load the 3rd metatarsal with pressure through the phalanx, and that hurts there, that's a sign of bone injury and not a soft tissue injury. So other ways of palpating the midfoot and forefoot now, which is counted anything metatarsal and up is forefoot, is to squeeze either the midfoot we can squeeze, or we can squeeze the forefoot. Palpation of the foot continues at the phalanx. On the bottom of the foot, you can feel the plantar plates, and if you extend the toes, that might irritate someone like a dancer who has a plantar plate injury. The MTP, the first MTP, is the most injured joint for dancers and non-dancers alike, football players. The first MTP, gout, can also cause pain and swelling here. If you have gout, the hints will be redness and a lot of swelling and severe pain in all motions. So flexion, dorsiflexion, plantar flexion, any motion, axial load, and of course palpation of that joint will cause severe pain. Fractures, of course, can cause pain anywhere that you can see them. Strength testing, so posterior tibialis tendon comes on the inside of the tibia and attaches to the navicular bone and helps with plantar flexion and inversion. So can you push down and in this way? Yeah, and resist plantar flexion inversion. That will be posterior tibialis. The opposite, eversion or external rotation and plantar flexion, is peroneal tendons. Can you push down and go out? That's peroneal tendons. You can actually see the peroneal tendons. If you turn your foot out here, you can see them tightening when your plantar flexion relax, and it goes away. Push down again, and you can see them tightening. That's posterior, that's peroneus brevis over here. So we have strength testing of the anterior tibialis. Can you lift your foot up? This injury, anterior tibialis rarely gets injured, but if you have drop something on your foot that's sharp, it cuts the anterior tibialis, it could be injured. Or if you have compartment syndrome in your leg from a tibial stress tibial fracture and reduction, fracture reduction, open reduction, internal fixation, and hard cast, that could affect that too. Extensor digitorum is just bringing all the toes up, and extensor hallucis bringing a big toe up, and flexor hallucis coming back here with the neurovascular bundle, bringing the big toe down. Now, the flexor hallucis comes around the backside to the posterior ankle. If you have a fracture in the posterior ankle, this will hurt with flexor hallucis function because it'll irritate that fracture in the Stades process. So, as well as possibly flexion of the toes. Can you flex your toes? Okay. Now we'll do some more special testing. One problem that we see in the foot and ankle, kind of like the hand, is tarsal tunnel syndrome. So the nerve can be compressed as it's coming through here. So if we want to stretch that nerve, like a phalanx test in the foot, we'll do dorsiflexion and eversion. That will stress the nerve and stretch the nerve, causing pain in the plantar surfaces of the foot. And so that could be a sign of tarsal tunnel syndrome, and you may have to hold this position for 30 seconds or so to confirm if they have it, if it's negative initially. Another test that might be a sign of tarsal tunnel syndrome is tapping where the nerve is compressed. So if you have a ganglion cyst in the middle of the ankle from playing soccer too much and getting injured, and you tap on that ganglion cyst and irritate the nerve, it might cause a shock-like sensation in the plantar part of the foot. Test for the anterior talofibular ligament, which is commonly torn. This is not a very good test. It's called a anterior drawer test. I'll do it on the other foot, but it's not very sensitive or specific. But basically, you put them in neutral position and you passively pull the foot away from the fibula, and if it's torn, it'll give way more. It's probably not the best test, so we don't really do it too much. Another similar test for the anterior talofibular ligament, for the calcaneal fibular ligament, the medial branch of the lateral collateral is talar tilt, and to do that, you tilt the talus away, and you feel if there's an in point or too much motion on talar tilting away from the fibula, and that might be a sign of an injury in the posterior talofibular ligament. Now, ankle foot exam also includes an exam of the Achilles. Can you roll on your tummy? To do an exam of the Achilles, we'll look at, can you pull off the table here? Come off the table a little bit. We'll look at the Achilles first, and sometimes you'll see fusiform swelling 2 to 3 centimeters proximal to the attachment. That's often a sign of chronic Achilles tendonitis. And if you want to check for Achilles tendon tear, complete tear, what we might do is squeeze just the gastrocsoleus muscle. And when you squeeze the gastrocsoleus muscle passively, you'll see automatic plantar flexion of the foot. If they have a complete rupture, this may not happen as you squeeze the gastrocsoleus isolated. If you end up squeezing the peroneal muscles or the posterior tibialis muscle too much down here, it might plantar flex and give you a false negative test. But a true positive Thompson test is you squeeze and then don't move. The toes do not go down. And that's a sign of a rupture of the Achilles tendon. We can check Achilles tendon stability too by having them plantar flex against resistance, or walk or go up on their toes, and you'll see abnormalities here. The best way to see this is ultrasound. Roll back over. We're gonna do a few more special testings in the foot and ankle, I think, that are helpful. One is to feel the sinus tarsi. This is a sub-talar joint. It's not the ankle joint, and the sinus tarsi can sometimes cause pain right in here, and that can even cause some swelling and be a sign of an inflammation disorder in that region. I think a few more useful tests include palpation of the medial calcaneal tubercle. Can you turn your knee out? And the medial calcaneal tubercle is right here, and that will hurt when patients have plantar fasciitis. But another common problem that patients can have, especially kids, is apophysitis or a stress fracture, and either will be positive with pain with squeezing of the calcaneus. So this will be positive for pain with plantar fascia, and this is positive for pain with calcaneal stress fractures or apophysitis.